As two practicing physician assistants, we've seen a lot and we've heard a lot. We know that you've heard a lot too. We are here to help you navigate through the BS by having open and honest conversations with other practicing professionals. I'm Heidi.
And I'm Cassie, and welcome to Mindfully Woman.
Hi, everybody, and welcome back to another wonderful episode. We have a awesome guest here with us today. She's actually a previous colleague of mine when I worked in family medicine, and she's an amazing person. She has so much great experience. Her name is Deb Taylor. She's a certified women's health nurse practitioner, and she's also a certified family medicine nurse practitioner. And she's had multiple years of experience, which I will, let her tell you about more. But welcome to the podcast, Deb.
Thank you, Heidi. Thank you, Cassie. Yes, I am so grateful to be here. So thankful that you asked me to do this. I love just the everyday conversation about birth control and see if we can kind of help some women make decisions.
That's awesome. Yeah, we are so glad you agreed to be on here. Before we really get into nitty gritty about a big topic we're going to talk about today, which is birth control, we want you to tell us a little bit about yourself, kind of your experience, how you got to where you are now, and kind of your route to being now. And you're in family medicine now, but you were in women's health for forever. So tell us a little bit about that.
Let's see. Well, I'm going to say my age. I'm 52. So, and the reason I say this is because I can say I've now gone through all the stages of contraception through hormone replacement, even though we're not really going to touch on that so much today. I've been a nurse practitioner since we'll just say 26 years.
That's amazing.
Now.
Wow.
So it's been a wonderful career, and most of my career, 7-8 years now I've been in family medicine, but I still do a lot of contraceptive counseling and a lot of GYN procedures and things. So it is in the heart of who I am as a healthcare provider. Mm-hmm. And I started out, I really didn't have an intention of being a nurse practitioner. I was a labor and delivery nurse at what used to be Wishart Hospital. And one night, one of the staff attendings said, "Hey, we think you would be good at this. Would you go? If we put you through school, would you agree to do this for a while? There's a great need."
Wow.
And
that's incredible.
Yeah, he was an amazing person. And at the time I was a young single mom, thought there's no way, how am I going to do this? But then, we just make it through what's handed to us. And, I started out trained with the residents at Wishart. That was years of amazing experience there. And then I went into private practice with a few very, very good women caring physicians that taught me a lot, not just the statistics and the what do you do, but really, really caring for women in their lives and making their healthcare match who they are. Amazing. So that's kind of been ingrained for me.
Mm-hmm. That's awesome.
That's wonderful.
I feel like you've kind of got that, really how to care for a person, versus just,
yes,
this is the data, XYZ, this is what you're going to do.
Yes.
Oh, that's awesome.
So I'm curious, what made you switch from doing so many years in women's health to family medicine?
There were a couple things. I was having a lot of really bad neck issues, and in the position of doing a pap smear, that word was really wearing on me. Oh. And I also found that I was doing a lot of primary care with a well women visit with little resources and knowledge to do what they needed.
Yeah.
And then I thought, well, what can I do with this later? I really didn't know. So I was like, I'm just going to sign up and go back to school and see where it leads me. And it just led me down the hall So, but one thing that it's been wonderful is I get great joy out of the family practice, family medicine world, that there's this gap of knowledge of contraception and day-to-day women's healthcare that they come to me, and I really like that. So
that's awesome. Do you feel like with that, because I know I personally, when I worked in family medicine, learned a lot from you, like when it came to women's health, and you taught me how to do Nexplanon procedures and how to like insert and take it out. And so like that was amazing. Do you feel like outside of that, in your family medicine little blub you're doing now, do you do like any kind of like in-service stuff, or do you talk to any of the providers a lot about like women's health, or do they just come to you if they've got questions?
They just come to me if I have questions. I would like to maybe get into that realm a little bit as lifetime allows. Lifetime.
Yeah.
We can add more hours to the day.
Yeah, right.
I would like to do that.
That's awesome. Oh, well, you've had quite a journey, from getting to labor and delivery to women's health for a long time. And then, now in family medicine. So I think that's great, kind of like going full circle and not necessarily closing the gap, but maybe even like opening the gap more to like being like even a more wholesome provider too. I think that's really great and speaks a lot to your character and like how good of a provider you are too, which I can attest for. You are amazing.
You are too, Heidi. Thank you. I miss you so much.
I know.
I understand.
Sorry, I took her.
She stole me.
Like I said, I don't blame her. I'd steal her back if I could.
You dabbled a little bit on like doing pap smears. So let's kind of go into like what you do for like women's health. Like tell us a little bit, even like kind of like maybe where you are now, to like the types of patients you see. And then like, do you do a lot of procedures still, et cetera? Kind of like walk us through like what your women's health practice looks like at this time.
It's a lot of contraceptive counseling. We are seeing a lot of teenagers coming in. I don't know if you know, but our pediatrics practice is now changed over to another umbrella. I don't know if I'm allowed to use like proper names with how that's working, but we're seeing a shift, I think, of a lot of teenagers coming in as new patients from the pediatric side to family medicine. I just saw that this week, like boom, that happened quickly. So that is an opportunity to start talking about, hey, are you sexually active? Not in a taboo way and not in a way that, there's little Disney characters on the wall, but really hey, by the way, in general conversation, you having sex?
Yeah. So important.
And are you, like, and if they're like, if they give me a little hint, like, I'm like, well, you need birth control unless you want to get pregnant. And then they're like, what?
What are you talking about?
So that opens the door, not only with the women or the girls or young women, whatever, but also with the males. Like, hey, this needs to be a conversation. So there's that. I do a lot of first-time PAPs, meaning they've never had a pelvic exam. They've never had a speculum exam.
Yeah.
So really walking them through and having them kind of sit up and going, okay, I made it. And that wasn't so bad. Like, yay.
Oh, that's good.
That
thing
has
is,
to feel good.
it's never fun to be in the stirrups. Like, it's never, you don't want to be here. It's not great. But if I can at least make it not as bad as what you thought it was going to be, then great success.
Yeah. I feel like that first time is always so important because so many women have such awful experiences and then they're going forward. They never want to do it or they build up so much anxiety around it. So that's great.
Yes. And you can just see the sheer fear in their face of like,
absolutely,
and so just really kind of normalizing that exam for them so that they are like, hey, Deb, check this out. So they're not afraid to come and tell me something's off for the next time.
Oh, that's great.
That's so great. We were just talking like yesterday about pelvic exams and pap smears too, and just how uncomfortable that is. And even working in like gyn-onc too, like we saw patients that had like really bad experiences. And by that time, we're seeing women in their 40s, 50s, 60s, and they're, so scared because they might have had like a really bad experience with a provider or a few providers. And then it's like, you kind of have to like walk them through it and just be like, it's okay. Like everything will be all right. You just have to, walk them through that. So that's a really nice and humbling experience for you too, to be able to do that for the first time for these young women.
Yeah. And I that's so unfortunate that they have a bad experience. And those, I think, can tend to be the women who then go a long time and not have a PAP, not have an exam, leading to seeing you guys in oncology. Right.
Exactly. Because then they don't do, they don't do it. They don't go. And then, we don't go. See them later.
And on the flip side too, like providers, I see even family medicine or those that are non-GYN, foundation based, I guess, not the right wording, but what I mean, that they are uncomfortable doing female exams. So they kind of are like, well, okay, you can just do that later.
Pushing it off.
They don't emphasize the importance of it. So then it gets pushed off even more.
Yeah, so. I've definitely noticed that just now, obviously out of gynonc now, but in breast, how many women have mentioned like, oh, well, I haven't had a pelvic exam since my child was born 26 years ago. And so, because they no longer see an OBGYN or a women's health provider, and the primary care doesn't feel comfortable doing it. And it always makes me nervous.
I see that a lot.
Yes, a lot. I don't doubt it.
I know. I honestly, working in like breast care, I never really thought about how truly like too wholesome it was going to be like for like the whole women's care, and like hearing these stories from women too. Like, oh yeah, we need to worry about your hormones and your ovaries and pelvic exams and paps. It's like, fortunate for us, we've had a little experience to like maybe guide some people in the right direction too. But
yeah, absolutely.
That's wild.
Yeah.
So that's great. I'm glad you get to see these young women. With that, we're kind of going to then dabble into the birth control side of things.
Yes.
So when you talk to them about birth control, kind of tell us, is all birth control the same? Like, is everything the same? Hormonal, non-hormonal?
No, it is not the same. There's some obvious commonalities with some hormonal birth controls, but they are not the same. And so that kind of leads me when I'm having a conversation, even if let's kind of start at the life stage where a new girl is starting out on her contraceptive journey of life, right? They are not the same. And I will have them come in and say, oh, no, I don't want birth control. It does this to me, or I'm afraid of this. And it's like, that was just one type. And we have a lot that we can talk about. So yes, that is correct. They are not the same. They are not only just hormonal and non-hormonal, but within the hormonal realm, there are many to choose from. So I kind of use I start with one, contraindications of what they cannot have. And I explain that to them, like and we're going to get into that. If they have one of those contraindications, I start and I go, okay, we're going to take that off the menu because those are not an option. And now let's go and look into, what do you think would work for you or work for you on a day-to-day basis? What do you think you will use? Because when we're looking at statistical efficacy, in a perfect use scenario, that can be very different with what a young woman has on her plate in life.
Yeah.
So
like talking about like if somebody's going to like take a pill every day or remember to take a pill versus having like an inserted device or an Explanon or something like that.
Correct.
If that would be better. Yeah. Or the depot shot. I guess that's another option, doing like an injection.
Correct.
Yeah. What do you find young women tend to lean towards? Do they want to start with a pill, or are they more worried about sticking to it and decide to do more of a like an IUD or the Nexplanon?
on the younger side, I see a lot of the teenagers coming in and wanting the Nexplanon because they just know, like, I've never taken a birth control before. I don't know if I don't know if I would remember. And some of that might be my leaning too. Like if I get kind of that feeling like, they're maybe like going back and forth between a shared custody situation, or they are traveling a lot with organized sports. Like, what is your life like? Is it consistent enough that you're going to remember to take this every day?
Yeah.
So like, we can make this much easier. And if you hate it, we can take it out. I always start with that. If you don't like it, you don't have to keep it.
Exactly.
So the Nexplanon is the Nexplanon is a very popular choice for that scenario. If I have a young girl that is maybe not sexually active yet, but thinking about it, and they don't know if they'll remember to take it, that might be a perfect opportunity to say, well, why don't we practice? Let's see how you do with it. If you find that you're not remembering it, it's not going to work out, then we'll choose something different.
Yeah. And just clear, Nexplanon is progesterone only, correct?
Correct.
Okay.
Yes.
Just want to make sure I have that straight.
Yeah. Can you maybe talk about a little bit too, like what, like the different, so like pills versus the Nexplanon and the IUD, like maybe what the different types of hormones that are in those?
Okay. So we'll start with that. We'll start with birth control pills.
Yeah.
I know there's like so many things to talk about.
I know.
There's so much.
Like, we could like squirrel all the way. But maybe that's why I like it so much. So within the birth control pills, we have combined oral contraceptives. And when we say combined oral, we mean that's estrogen and progesterone. Okay. And then we also have progestin only pills. And those each have their little risk, like not just risk, but risk and benefits and who those would fit better for than some. Did that come out right?
Yeah.
Then in the hormonal world with pills, we also have IUDs that have progesterone only. There is no IUD that has estrogen and progesterone. Okay. Then there's also a non-hormonal IUD. It's Paragard is the only one we have out. We have the Nexplanon, which is an implant that goes right under the arm. That is progestin, just progesterone only, no estrogen in that at all. And then we have the vaginal ring. It's estrogen and progesterone. Okay. There's one, you use it monthly. So there's two. There's one that you put a new ring in every month. And then there's another product that it's the same ring that lasts for a year and you take it out. Like use it for 21 days, take it out for a week.
Really?
And
I didn't know about that.
Yes. I didn't know about that either.
It's great that you only have one device. It's a little bit more cost up front.
That's what I was wondering. What's the expense of that? Okay.
Yeah. So I'm like, I don't know. Maybe it's great. Maybe I guess you don't have to go to the pharmacy as much. So I always try to find the benefit of each thing. Like, this might work for this situation and this might work for this situation. Then we also have our barrier methods, your condom, your female condom. And then there's spermicides that you can get that come in a film, the sponge, the gel insert. Let's see, what am I missing here? I feel like there's so many options.
That sounded good to me.
Yeah.
That was great. And the kind of the way you talk too is kind of like maybe like most efficacious to like least in terms of like statistics, like what works the best. Not always though. I think IUDs are a little superior to like birth control pills. And then kind of like the non-hormonal options that you just talked about, maybe like a little less just because of like consistent use and or risk of something happening or not working.
Yes. So when we see a lot of like statistics put out in data about contraceptive efficacy, a lot of it is based on perfect use. And no one's going to use anything perfect.
Yeah.
where IUDs can have that higher efficacy is because we're taking out a lot of that human error for getting pills, that not putting the ring in on time.
Yeah.
You know, the less amount that a woman has to take care of it every day, the less chance for error.
So true.
Mm-hmm.
Makes sense.
So outside of the obvious, like birth control, it literally the name to
prevent
pregnancy. Why would some other women choose to be on birth control outside of just not wanting to get pregnant? Maybe hormonal birth control. Like why else would they choose?
Teenagers, young girls come in for helps clear up acne. So we're decreasing those testosterone levels there. So that helps. Dysmenorrhea or painful cramps. It can be debilitating for a lot of young girls, young women, all ages. I say this new birth control. I think I'm concentrating a little too much on the young, but cramps. It also lessens the overall bleeding amount and the days that you have bleeding.
Mm-hmm.
Predictability.
Yeah.
You can schedule your periods. You can know like, oh, I'm going to schedule a vacation here, or I'm getting married here. I can really time out when I'm going to have my period.
Mm-hmm.
Yeah. Those are the most obvious.
That's awesome. So we talked a lot, you like younger women, kind of like a question that popped in my head because we see a lot of women who are like perimenopausal. Do you tend to kind of like maybe push a little bit to use birth control if they're in this like perimenopausal time frame too, and they're like, I don't know, like 40s, and they're like just struggling so much with period irregularity and just all kinds of symptoms?
I do. And now the dosing and the types that I will kind of lean toward helping them choose is different than I will for my younger patients.
Mm-hmm.
But absolutely, that can be a time of life. It's very disruptive for this unpredictable bleeding, sometimes heavy or skipping periods, and the moods that go with it too, like just the overall feeling of anxiety, sadness with the perimenopausal type. It can be really helpful to be on something.
Mm-hmm.
Yeah.
So do you typically use like the combination pills then for the perimenopausal women to help with more of those systemic or the moods and sleeping and that? Okay.
I will if there's not a lot of overwhelming contraindications to using them.
Gotcha. Yeah.
So if I have a patient that like on paper perfect, they're not a smoker, they have no migraine with aura, if they have not had a history of a DVT or a problem with anything that would increase their risk of coagulopathy or clotting, then yes, I will say, I think it's safe for you to be on a very low dose combination product, and let's get you through until you're menopausal.
Yeah, absolutely. That's what I was just going to ask you. How long do you tend to keep them on it for? And then once they do get through it, then do you switch them to hormone replacement therapy, or do you kind of weigh risk versus benefits, or just sort of curious how you approach that?
I'll once again address that risk versus benefit thing.
Yeah.
Because things change, right? Like,
absolutely.
Oh, okay, you were prescribed, you were on the pill, and now we have some other things going on. So we need to readdress this and maybe take it off the table or just change what we're using.
Yeah, absolutely. Okay.
I think that's one thing I personally struggle with a lot is like the dosing of multiple different types of like the combined oral contraceptives. Like, to be honest, like it's never something like I dove into too much. So like when you see this list of birth control options, I'm just like, where do I even what dose do I start with or what have you?
And like you mentioned, there's so many options, and
there are.
It can be quite overwhelming.
It is. I usually, and I think we talked about this, Heidi, is like pick a few names that
Yeah.
And, in the beginning, when you're learning how to prescribe birth control, is really look at, does it have estrogen or not? And make sure that you're not giving an estrogen containing product to a patient that has one of these, top 10 contraindications, like migraine with aura. No, do not use estrogen in them. It's twofold increase in the risk of stroke. So you don't want to do that.
Yeah. And so 1 second, just to clarify for listeners, migraine with aura is when you actually have this whole
like a halo, like light change, like when you see like fuzzy,
like all these symptoms that come on before the migraine actually happens. So you can lose your peripheral vision, you can get numbness, tingling on one side, so if you do have that, then PSA, don't be on estrogen.
Yes. Also, if carcinoma of the breast, so breast cancer, you would not, either personal history, known or suspected, you would not give that person combined oral contraceptive. And probably not progesterone either. I would before I would prescribe anything in the hormone arena of birth control for those patients. We need to have a conversation with your oncology provider.
Yeah. We see a lot of dual estrogen and progesterone fed breast cancer. So we always, if it's positive for that, get off of your birth control or IUD or what have you.
That is about, the first thing that we do. The first visit is, are you on any hormones? If so, you got to be done.
Unfortunately.
So.
It's kind of hard shit. But okay, so migraines, breast cancer, and then what are maybe some other ones with estrogen?
Smoking over the age of 35.
Okay.
And I have to tell you, like, I've kind of walked in a little, not fearful of a patient, but like, I'm going to brace myself because as soon as I say I'm not prescribing that, they're like, so, it's like, I'm going to help you quit smoking.
Yeah.
We need to change to an alternative until you can come in and say, like, I'm free of that. Just the risk of stroke.
Yeah.
That. And when you're in practice long enough, you will see it happen. So
is there a certain time frame? Do you wait like a certain amount of time after they're quitting smoking, like a year or 2 years, or if they really, really want to be on like an estrogen containing product?
Oh gosh.
That's okay if you don't.
I don't know that I have an absolute rule because I each scenario is so different. I'll have women come in and just say, you know what, I'm okay off of it, or I've stopped smoking, and maybe it just happens to have been like 3-6 months later and they want it back. Or they're happy with now that I've changed them to an IUD, or there's so many scenarios. I would have to look up some more data on that, but my gut wants to say 3 months not smoking. And if you start smoking again, please be honest with me. I will help you.
Exactly.
And that's,
and is that,
please don't lie.
Is that just tobacco, cigarettes, or what about, now there's so many like other nicotine options, especially like vaping, things like that. Do you take vaping into consideration? Like you put that in the same category? Yeah,
I put that in the same category.
Just curious.
Fair. I mean, I would too, honestly.
Yeah. It's like, it's not well studied. We don't, we just, I feel like it's safe to assume that it carries about the same risk.
Yeah. 100%.
So,
if not more.
Not more.
There's just so much more in it too.
Yeah. Agreed. Like the absorption rate of nicotine seems to be so much higher.
Yeah, definitely.
Just from what I've read. Yeah.
Another would be any kind of, if they're going to have a major surgery with like really long immobilization. I don't see that too often, but I've had a couple of like young patients like, they're going to have a hip surgery. And then they're, going to be down for a while. I'm like, maybe we should switch you. And then the answer is, well, I won't be having sex during that time anyway. So I'm like,
That's funny.
Or if they have had a history of a stroke.
Oh, yeah.
Yeah.
Like, Yeah.
Super high risk.
Blood clot in their legs or their lungs. That too. Yeah.
What
More
about
familial.
like progesterone only? Do you see, like, what are the big contraindications with using progestin or progesterone?
Some of the same, but less. So I really concentrate on getting them off of the estrogen. Sometimes I'll bridge to a progestin only method until I can get more answers about their certain case. I would not see, this is the part where you kind of get backed into a corner, because now you have this woman sitting in front of you who desperately does not want to get pregnant. And so then we start getting into the weeds of, are there risks? But are you willing to take those risks to not get pregnant? And then weighing that, what is the risk of pregnancy going to do to you?
Yeah.
So, in a perfect world on paper, sometimes I'd be like, I really don't want you on this, but what can we do? And the short answer to some can be, well, just use condoms. Well, have you looked at the efficacy data on condoms? Not that great.
That's tough. I feel like,
or they leave and they're like, well, my husband's just going to get a vasectomy. Yeah, well, that appointment's like 5 months out. So what are we doing?
What are we doing till then? Like, how are we going to bridge that gap?
Can still get pregnant at any time during that. Oh, yikes.
And there's so many like socioeconomic impacts of that. Like, can you afford to have another baby? Like, maybe if you've already have a few kids, or if this is your first child, like, is this a feasible option? Are you working, not working? Do you get time off? Those are like really hard things to juggle in life too. So I understand it can be really tough conversations to have.
Right. So I feel like I really get, not backed into a corner, because some of it's like a puzzle to help the patient. Right. So those are the tough cases where you're like, okay, we have this, and this. We can't use this, and this. We might be able. And that leads me to the CDC app, the medical eligibility criteria, MEC. And it's online. I mean, we can download the app. I think we pay a little bit for it, but it is a great reference for not only like other providers who might be seeing this, but also patients who want to see it. It goes at the app, or the that criteria bulletin goes by each condition. Like, this is what you have, and is it a category? Like 4 would be an absolute do not use, and then going down into where maybe the benefits may outweigh the risks a little bit.
Yeah.
Oh, very interesting.
I remember. Yeah, you told me about that when I used it a lot.
I'll say I might have to look into that.
It's super helpful.
It's a great app. Download it today.
Yes, I will. I do want to ask. So these women who you don't feel quite comfortable putting them on any hormones, but you also want to prevent pregnancy. Do you ever talk about like the family planning, like learning your cycles and timing around ovulation, or preventing sexual activity during or around ovulation?
I do, and this is where I kind of have to admit, like, I have a very personal bias on that one. Because fair. I just don't think it works well.
Yeah,
fair. Yeah.
And there's going to be a whole slew of people like, oh, if you are very regimented with it, it can work, it can be helpful, but that is such a very small percentage of patients that can do that, where their periods are perfect. That I just tend to like, my question to the patient is, how much do you not want to get pregnant?
Right. Right.
If they're like, I'm okay if I conceive in the next year, that would be fine, then great.
Yeah.
If that is not just life-disrupting to you, if you're kind of half planning it, great, then you're the perfect patient that can say like, yeah, cool. If they look at me and they go, I 100% do not want to get pregnant. I can't, I don't want to, then we're not going to look at fertility awareness method because And what does your life look like?
Exactly.
Yeah.
You're, running here and there to jobs. Can you do this? Can you keep up with it? Or are you looking at me with your scheduled calendars like mine or whatever? Like it's a lot of work to take care of that. So it's like,
absolutely.
let's choose something else.
Yeah. And you have to be so consistent, so regimented about it. Like you said, you have to have a perfect period and know exactly, okay, these are the symptoms that are specific to me to tell me where I'm at in my cycle. So I totally agree that.
Yeah. The textbooks don't tell you like adult life hits and everything's crazy. How am I supposed to look at when I'm ovulating?
But and I have to say we are in a resource rich environment. So while we do think of cost and we do have socioeconomic factors that play into our contraception use here, we do have a resource rich opportunities to get things. And why I'm saying this, I was helping teach some fertility awareness methods, and we were taking the beads over to the Dominican when I did a mission trip over there.
Yeah.
So my whole thought in what we do over there is completely different, because I can't get a hold of birth controls. Where are the condoms going to come from? The stigma is different on birth control there. So
that is so wild.
Oh,
and so
very
cool
interesting.
that you got to do that. I mean, how awesome. What an experience. That's great.
It cool. Like, okay, let's go back to those roots. What did I learn in the textbook? So maybe all they have to be able to help them not conceive for a little while.
Yeah.
So.
Speaking of those hard conversations that you have with people and maybe some tough times like that, pivoting a little bit into like the side effects of birth control that, women don't want to hear about or experience.
Makes it hard to sell.
Yes. How do you sell it? And I guess kind of talk about those side effects that could happen with birth control.
Let's pick a birth control.
Yeah.
You guys pick one and we'll go.
Let's do pills. I feel like pills are common.
Okay.
To talk about.
Nausea is one. So I will tell patients, take it in the evening with your biggest meal. At first, we're going to talk about you take it the time of day that you will remember it the most, right? But the time of day and meal time can really help with that, getting a new start on with nausea. Irregular spotting. It's very common to have some breakthrough bleeding the first 3-ish cycles. Every date is a little bit different, but we'll say 3 cycles, 3 months worth of maybe some breakthrough bleeding until you get accustomed to it and that lining gets thinned out. And at the end, you'll have less bleeding. We talk about weight gain. That's always the biggest question. Like, am I going to get fat? My quick answer to that is no. Birth control does not make you fat.
Good.
There are exceptions to every rule.
Of course.
But, if they're not on birth control and they're, playing with fire with getting pregnant, I always say, you want to know what really gets you fat? Getting pregnant. So when they're like, oh, I'm like, yeah.
Oh my gosh,
you want to gain 30, great. 40 pounds instantly? There you go.
That's awesome.
So then they're like, oh, okay, yes. But leading to that, the weight gain for generally with birth control pills, it's not been, studies just can't show that happening. Now, and the same goes with like the ring, the patch, which we haven't really mentioned, IUDs, where if weight gain has been a problem or I'm really worried about that, I look more into the Depo-Provera injection.
That's what I've always heard.
I had to say, like, which one, if I was looking to have someone gain weight and I had to choose from that, I'd go, oh, get that one.
Yeah.
But not everyone. And I'll if a patient really wants that one and it's a little worry, I'm like, well, let's try it. Let's try it, 3 to 6 months and see how you do. You may not be one that gains weight. And I have had plenty of patients that lose weight on it, feel great on it.
Yeah.
And so they don't.
And you're
So.
talking about Depo-Provera, so progesterone only injection.
Correct. Okay. Yes. Yeah.
What is it? Why do people think they gain weight when they're, is it like water weight too? Like, can you like retain maybe some water? Like what's the huge correlation in terms of
the water weight gain is typically associated with the estrogen.
Yeah.
And that's pretty transient. That'll go away. It's, I think, an increase in hunger.
That makes
glycemic, with
that makes sense.
progestin.
Interesting. You know, I never really thought about that either. Kind of like it's not actually causing weight gain, but all these women tend to like associate it because that's what they started when then they gained, 5-10 pounds down the road. But so interesting. Wow.
Yeah. And too, it's like, I don't know a lot of even providers even look at this either, but a typical age when a woman is starting birth control, we'll say 16. And they're in their senior year of high school, and then they go off to college, or maybe they're starting it. What happens in their life then? Right. So their body is already changing. They're going to gain some weight. Their diet changes. Maybe they're stopping their organized sports or whatever that they were doing in high school. They go to college. So they'll go, oh, why am I gaining so much weight? Well, they're like, oh, I started birth control. Boom. So they put those two together.
Yeah.
It's like correlation doesn't mean causation.
Yes.
Yeah.
So and I don't ignore it. I don't ignore it with them because that's
exactly.
It doesn't feel good, but I'll like, okay, what else is going on in your life? What can you do? And what can I do to help you?
That's so smart. Yeah. That's great.
Yeah,
what do you feel like is, maybe like with that too, I feel like kind of weight gain obviously kind of dabbles into that like field of maybe like misinformation that can happen with birth control. What do you feel like are some big things you hear with hormonal birth control that's like misinformation or something like you wish you could tell women like this is not true?
I'm surprised at how often I still hear, is this going to make me not have children later?
Oh, yes. Yeah.
Like birth control is going to somehow ruin their future fertility. And that is that big myth. It is not. It's actually can be quite the opposite, because if we look at the percentage of women who may have some endometriosis going on, or getting into the weeds of just thickening the cervical mucus, and it can be helpful with preventing pelvic inflammatory disease if you were to contract one of the STDs that can cause that. Decreasing that ovarian, your ovaries turning over, cell turn all the time, decreasing that. So I tell women like it can be actually quite the opposite. So
that is actually, I'm so glad you brought that up because we talk about that a lot. To be honest, something like we maybe like need to study more or look into more, but we see a lot of women, younger women, I would say like maybe like 20 in 20s, upper 20s, 30s, who maybe have been on birth control since they were like 15, 16. And we see them maybe like wanting to get off of birth control because of that possibility, like maybe not being able to get pregnant or really struggling to get pregnant, or maybe their cycles have been like super irregular, like since they stopped birth control too. And so like trying to like to find their new balance. So I'm glad you brought that up because it's something like we wonder about, we talk about, things we need to look into more too, but interesting.
How long does it typically take, or even if there is like an average number of cycles after stopping birth control? Like, could you get pregnant, right away, or is it really person dependent?
You can conceive it like within a week of usually stopping a lot of contraception. So, and it used to, I still hear this myth too. It's like, oh, I have to be off the pill for 3 months before I try to get pregnant.
Yes.
And it's like, no, you don't.
Yeah.
You don't. You can just start to try to conceive right away. And I still see it in some of the infertility realm where they're like, let's go on the pill for, a few months, take you off, and let's kind of restart those cycles and see if that helps.
Oh, interesting.
Yeah.
Yeah, that makes sense. Yeah. Huh.
What's one thing you wish women understood more about birth control? If kind of things I guess we haven't already talked about. Is there anything like you wish women knew more?
Gosh, there's so many things. I know we talked about this.
You can pick your top three. Your top three things.
Oh, one thing I wish they knew. Just how it works in their body, what it's doing, that there can be great benefits to it. Have the conversations. Oh gosh, I'll have to come to. I had so many great answers for that question, and it's like every day it's more case by case. Like, oh, I wish that woman knew more about this, and I wish the system would give me time to actually teach them, each person, more.
I think you brought up a great point though with like the fertility. I think that's a great thing you brought up. Concerns. A big misunderstanding. And maybe things you wish women would know from the get go if they're like super scared about being on it, young or even like older adult too, or like maybe in their 30s. Like it'll be okay.
Another thing that I still hear that I wish I could just put this like great big PSA on it. When we teach, like when you stop having periods on birth control, and we show you how to do the continuous dosing, young women or even, middle-aged women, whatever, will still come in and go, well, that's not healthy. I'm keeping all this in there. Like, doesn't it need to clean itself out? And I'm like, no, no. And they look at me like, but that's not what my grandma said. And that's one of the things I'm like, we should learn lots and lots of things from our generations ahead of us.
Yes.
But probably not about birth control because it has changed so much.
Yeah.
And I feel like that's really a hard one to get patients through, is that if you are on a method that is keeping that lining thin, the inside lining of your uterus, you don't have to shed it. And I can't believe I still use this analogy, but it seems to like resonate or seems to work. So people, if you live in the desert, you don't have to mow your grass because you're not growing any.
I know, like that.
It's so goofy. It is so goofy. And they look at me like,
makes total sense.
And I'm like, when that yard is allowed to mow your endometrium, you need to mow it. You got to shut it off. But we're going to keep you from growing it in the first place. So there you go. Less bleeding, less.
Okay.
So it's like we're not creating a danger in there.
Yeah.
So.
That is so awesome. I love that.
And is it true that, so like your placebo week or the very last pill week of a pack, that your bleeding is withdrawal bleeding? It's not necessarily like a true period. Is that correct?
True.
Okay.
Yes.
Okay.
And that actually came about when they first developed birth control pills. They thought it would be more acceptable for women to take if it mimicked what was going on naturally. There's no reason. And it's still, I still have this too, women who are on consistently taking their pills or consistently on with their IUD or whatever method it is. If they do not have that withdrawal bleed, they fear and they run and go get a pregnancy test. And I'm like, you don't really, you'll get used to this and usually they'll stop, but it's an instant fear. I'm like, that's expensive. So even if you're getting them every month at the dollar store, like,
right.
That's funny.
Adds up.
you don't have to do that.
Yeah.
So, but then that also leads me to a conversation of, okay, well then let's go ahead and start doing some continuous dosing.
Mm-hmm.
So you just,
Don't
if
have
you're already doing so good at like not having a period, let's really make it not happen.
Yeah. They're okay with the desert grass not growing and they're just going to keep on.
Yes. And then I go to that goofy analogy I have that just still keeps working for me.
I love it. Oh,
I was definitely well into my 20s and on birth control for years before I knew that I didn't have to take the placebo week. I was very upset when I've been having these periods for what?
yeah. Same like PA schools when you like really learn about it. And I was like, oh, wow.
Yep. And I had the migraines with Aura and on estrogen. No idea. Yeah.
Where was Deb when we needed her?
I needed
in our life?
Then I went to PA school and I was like, oh my gosh, I have to change this right now.
Yeah. Yeah. I still see that a lot. And it's just, I think
scary.
I see it more in unfortunately, more in like the primary care realm when we are just throwing birth control into all the other things that we have to get done within a visit.
Yeah.
Yeah. 1,000%.
Mm-hmm.
That's, it was my primary care provider. Mm-hmm. And I mean, I don't fault her by any means. It's like, did this be on this and
go forth.
Yeah. And I didn't start having migraines with Aura until really later in life, like when I was on hormones or on the combination pill. So it was very interesting. Anyway, I'm good now.
She's all good.
That's good. Well, no estrogen for you, man.
Yeah, no estrogen for me.
So a question I asked you before we really started recording is I want to know what your thoughts are on women being on birth control, young women, let's say young. We'll pose a scenario. Young women being on birth control for too long. Do you feel like there is the possibility that women are on it for too long? Like, let's say from the time they're 15 till, 30, 35. So, what are your
50?
Thoughts? Yeah, 50.
50?
50? Yeah.
50? Yeah.
All the way through. What are your thoughts?
I think we are at a time, especially with all like I'm going to kind of go squirrely over here.
That's okay.
It's my way, right? That we're in a time where there's so much genetic testing and so much more awareness of cancer genes and what's happening.
Woohoo.
And I'm not sure how much that plays a part, but as far as like how long, I have not quite changed my patient counseling, and like there is no too long of a time. In that is now take away the possible contraindications, right? Those are going to change over a woman's lifetime. But if you don't want to get pregnant, you don't want to get pregnant. And so that's the main thing. It's like not getting pregnant. But we also need to look at, maybe this patient has had a BRCA1 test. Maybe we have more family knowledge now. Those things change. But as far as say a young woman comes in, she's 16 years old, wants to be on the pill, never wants to have children, never. And now I've seen her, and I have a few of these patients that now they're 25, now they're 35. They still don't want to get pregnant. And they look at me and they go, do I have a time that I have to be off of this? It's been 20 years. Are you taking me off now? No, I'm not. But within that conversation, I will still say, you need to keep up with your healthcare. When we tell you it's time to get mammograms every year, you need to tell me when you have any symptoms that we need to look further, like new family history, that kind of thing. But as far as just an easy scenario of low dose combined oral contraceptive, no. I'll just tell them, just keep going. I'll coach you through menopause.
Okay.
Yeah. And super patient specific too. I guess a big controversy, let's say it that way, a big controversy or something we see, but we are also extremely biased in this regard because we are seeing young women, not a genetic mutation. We're seeing women in their 20s to 30s who either maybe have a non-hormonal breast cancer, or we are seeing those who do have a hormone positive breast cancer at a very young age. And we're trying to figure out why, why are we seeing this? What is it? Is it our culture? Is it our diet? Is it the environment where we've lived, how we grow up, the generation preceding us, and maybe exposures we've had through that? So it's really hard to figure that out and kind of navigate all these nuances with kind of like some big changes in healthcare and women's health, particularly because, as you know, hormones are a huge thing, on the forefront right now, which we will dive into later and maybe have you on again to talk about that. But it's just so interesting to me. And so that's a question like we are literally asking ourselves right now. And, the surgeons we work with is like, why? What is it looking like?
Yeah. I don't, and those are like questions I don't think any of us really know the answer. And I say that like my patient, like what I'm counseling patients, like right now, what am I saying? I have in the back of my mind, is this going to change? Like, what data are we going to have in 5-10 more years? And what is that going to look like?
Agree.
Is it really what that woman's doing, or is it the generation before, or is it the hormones in our food that we're getting? Like, really, where is it coming from? Will we ever know?
That's why I feel like there's so many factors that are we really ever going to be able to narrow it down to just one thing? I feel like there's so many things that can impact our risk. So I agree. I'm very interested to see, okay, in 5-10 years, are we going to have enough data to point us in the direction of what it might be coming from?
Yeah. I think working in medicine too, like, you want to fix it. Like you want to be like, I don't know, I want to figure it out. Like, why do we have to do this? But I think that's kind of also like the beauty of working in medicine is like, it takes a little bit of time. It takes research. It takes, kind of just walking through step by step like you do, it's super patient specific, and you got to take every case by case and like look at what's changed in their personal and family history. And then, go from there and evaluate all the risk and benefits, pros, cons.
Right. Yeah. And I mean, I know we're not really touching on hormone therapy, and hopefully we will another day. But when I first got out of school and was practicing, it was, everybody gets hormones and it prevents dementia. And it was, you're going to take it and you're going to take it for the rest of your life. You don't have to go. It's just very, very different data. And then the Women's Health Initiative came out, swung that pendulum the other way. And then that data got looked into a little further. The pendulum swung a little.
Yeah.
So it's,
it's hard.
Yeah, so
absolutely.
Cool. Another quick thing on that too, birth control, not the same as hormone replacement therapy, correct?
Completely different dosing. Yeah. So the amount of estrogen, progesterone that's used in hormone replacement is a fraction of the amount that's used with birth control.
Interesting.
And different types of progesterone, and there's a whole nother.
I know. We've talked for quite a long time now just about all this stuff with birth control. So I would love to have you back on here to talk about some hormones stuff.
Yeah, absolutely.
That would be great. And that's why I said to like my age earlier too. It's like when I first started, I was not as comfortable with having a conversation with an older patient about menopause because I was in my early 20s. I was a pretty young NP. So they were not going to like, you don't know what you're talking about.
Yeah.
But now I can have those conversations and then they look at me like, yeah, you get it.
You're like, yes, I've been through it.
True.
Yes.
I will say.
But
that's one of the benefits that, the longer you work, the more trust, more trusted you are.
Yeah, absolutely. And then going through it personally as well. Like you can be like, I vouch for those symptoms that I think Heidi and I we hear a lot of menopausal symptoms because in our field, unfortunately, we are taking away all the hormones. And so we hear the symptoms a lot, but we are 30, so we haven't unfortunately gone through that yet. But now I'm getting to the point where I'm like, I feel like I'm going through it too. I hear the symptoms so often. Of course, it's obviously not the same at all. But I hear the symptoms so often. I'm like, yes, I hear you.
It's like you feel so horrible. Bad.
Oh, it's coming.
It's coming. That's why I'm like, oh no.
Yeah. Oh, you know what? That kind of leads me to another. We were talking about dosing with hormone therapy replacement world versus birth control world. Is I have a lot of patients that'll come in and go, I want the lowest dose possible. That's another myth that I wish women knew. The lowest dose doesn't always mean better. Right. Now, birth control has changed over. I mean, it wasn't uncommon for me to write a 50 microgram pill. And you guys are probably going, what? 50 micrograms? But yeah, we did. So wow. I don't want to say all, but birth controls are 35 micrograms and less. So they're all in, they're much lower doses now versus, a couple decades ago.
Yeah.
So, but in that realm, on paper, I could write you the absolute lowest dose, but that also might mean more side effects. Exactly. And you may not feel as good on it. Yeah. So that is kind of a myth to saying you want the lowest dose. That doesn't always mean the best.
Why is that? Why are there more symptoms or tend to be more symptoms with the lower doses?
Just stabilizing that endometrium and breakthrough bleeding and that balance of estrogen and progesterone. Gotcha. I think, Heidi, when you were in there, we would break out the Dicky book.
Yes. Yes, we would.
Yeah. My prize.
What is that?
Holy Grail.
When you know, you know.
When you know, you know now.
When you know, you know. The Dicky book, oh gosh, I should have, before I brought this up, had all my facts straight. But it was a book that was put out for many years. I don't think, surely it's not in production anymore, but it kind of goes through with managing oral contraceptives. And if you had breakthrough bleeding in the early part of the cycle, how do you adjust your pill for your patient? If you have breast tenderness, where do you move to? What's a good one to start with certain situations? Or certain, theoretically, what you would prescribe for a patient with PCOS might look a little different for one that's not, or that.
Gotcha. Huh. I want that book.
And the Dicky book was this book algorithm that helps.
That sounds wonderful.
She is also the wizard of resources and algorithms and everything. She's she has
all right, I want to come work with you for a month.
She'll hook you up for sure.
Now, where I find that's where other things play. I have that, but let me find it.
Yeah. Where should I put that again?
oh my gosh, Deb, it's been so great talking with you.
It's been very nice meeting you.
Absolutely have loved this, and I'm so glad I got to see you again via Zoom. Yes. But is there anything else that you want to add? Is there any other interesting facts, statements, anything? I know we've talked about a lot, and you've dropped them here and there, but anything you just want to end on?
You guys keep doing this, please.
Oh, thank you. Appreciate it.
I'm going to love having patients hey, check this out. Look at this. Please watch. And having resources for patients that is real data and not, like I said, we learn a lot from our grandmas, but birth control is probably not one of them that we should. But resources for patients that they can get real world experience from healthcare professionals so they get rid of those myths.
Yeah, absolutely. That's
100%. That's our goal here.
I was going to say that's 1,000% why we started this because talking with patients, we're like, no.
Personally, I've gone down rabbit holes myself and
absolutely.
I listened to some different health podcasts before we started this one, and I'm just should I only be eating meat only for the rest of my life? You start thinking is this what I need to do? And then I'm no, get off of this.
And then you can go down another one that says you should only be eating green vegetables ever.
Right? Juicing only.
Yes.
Exactly.
And
And
you're
so,
listening to the podcast, like eating the chocolate.
yeah, I'm like, oh no.
What?
So,
Is that the problem?
we appreciate you saying that so much. Yeah, we definitely will. And this is really what we want to do, is have professionals on here with real world experience who can speak to this. And this has been so great.
Yeah. So thank you so much, Deb, for joining us.
Thank you for having me. It's been so fun.
Not a problem. Yeah, maybe
welcome.
have you on in the future to talk more about hormone replacement, depending on, how comfortable you are with that.
Yeah.
Yes. And I would love to pick your brains too. Like,
of
how
course,
from someone in my position, like, how do we bridge that knowledge gap with what you guys are seeing in oncology, and how do we make it better? Because I'm sure there's some things that you'll get a patient and you're like, oh, I can't believe they were doing that.
100%.
Prescribing that. And, we're still running around here unknowingly doing things, right? We should know, but it takes time so to like maybe bridge that gap of
absolutely
what oncology would like us primary people to know.
Yeah. 100%.
Yeah, of course. Very controversial. And I don't know if I should say this or not, but we have been seeing more increase with like functional medicine stuff, throwing a lot of hormones out there. And we've been seeing a lot more cancers with that. So would love to do that as well. And kind of like you said, bridge the gap with that too.
Yeah, I'm glad you brought that up, because I am seeing some pretty scary things in that arena of
yes.
Maybe we should have
we're not the only ones.
We should have a scary things in medicine episode. Just kidding. I don't want to scare anybody. We're just going to give you the good stuff. But thank you so much, everybody. And we will see you back here soon with another episode. But again, thanks for being here, and we love talking to you. It was great.
Thank you.
Yeah.
Thank you, Heidi and Cassi.
You're welcome. Bye.
Bye.
The information that you hear on this podcast is not a substitute for medical advice. As always, please seek out personal care and advice from your medical team.